Association. And we have Nancy Kaufman from Toronto East General, who together they have put together quite an awesome program that I was able to learn about at an OHA seminar that I went to several weeks ago now, and was very happy that they agreed to travel all the way out to Belleville from the Toronto area to come and present this wonderful PowerPoint to us. So, thank you.
Hi everyone, and thank you for having us. We're quite excited to be able to share our experience, our journey related to workplace violence prevention at Toronto East General. Erna and I have been working together at Toronto East General for probably 8-9 years. And prior to that, just by coincidence, we used to work together in private sector. So we have a long history of partnering and collaborating together. And we should sort of start off today's presentation acknowledging that while we think we have a healthy and comprehensive program, we have learned that it's always a work in progress. So it helps that we're a plan, study, do, act organization, because just when you think you may have all the bells and whistles of a comprehensive program, some incident occurs, and through a debrief you learn something new, or we have been partnering with ONA to go out and meet with a lot of different organizations, including ONA's Health and Safety Conference Circuit. And we learn as much by coming out and hearing from you as well. So what we're going to share with you today is our program as it sits today. It will not be the same program 3 months from now nor a year from now. What we hope to do is just share our lessons learned and recommendations that we have learned through the good, bad, and ugly journey for the last 6 or 7 years. And if we can answer any questions at the end of our presentation or during the presentation, that's where the learning happens for us. So I don't know whether you're familiar with Toronto East General. I'm not going to give you the long version, but we're a small community teaching hospital in southeast Toronto. So we're not down on University Avenue, but we are a very vibrant community teaching hospital. We probably have the busiest emergency department in all of the GTA, and we have the second largest inpatient mental health unit in the GTA next to CAMH. I'm sure all of you have your own mission, vision, and value statements. I put it up here just to simply talk about the fact that a lot of what we're going to talk about today is, of course, when you get right down to it, a health and safety program, and more specifically, a violence prevention program. But what we have learned throughout the years of talking and debriefing from workplace violence incidents is it's really about a cultural initiative. And if I had lesson number 1 to sort of offer up is that in terms of collaborating with your stakeholders, to think more of workplace violence prevention of a culture of caring, as opposed to getting down into the weeds of health and safety, or it's a labor relations management issue. It is really about coming together and understanding what kind of culture you want to be, and this can be one of the mechanisms or vehicles that you can practically demonstrate what your culture is. I want to share with you this is our current corporate strategic plan, and I'm not going to get into the details, but each of our 4 major budget buckets in the corporate strategic plan has only 2 tactics that are highlighted, and one of those 2 under encourage people for our corporate strategic plan has been for the last number of years, and currently has as one of the 2 tactics, specifically talking about role modeling excellence in workplace safety, engagement, and wellness. And I raise this because as an HR professional, everybody thinks it's really easy for me to come into a business room of operational directors and boards of directors who, are business people at their hearts, and talk about culture and safety. And it's pretty challenging. You have to learn to sort of talk the business talk, and in order to capture the imagination, the interests, and the financial resources of a large organization, you have to put the issue of safety and culture in a way that can be heard. And the way that can be heard, certainly at our hospital, is through a focus on our corporate strategic plan. This is not the HR strategic plan, it's not even our health and safety or wellness strategic plan, it is the corporate plan that the board of directors reviews. And so on a quarterly basis, they are getting updates on all things related to wellness, engagement, and safety, including how many critical and severe workplace incidents we've had and what we've done about it. And I can tell you it goes a long way as an HR professional when a member of the board of directors asks me if I need any assistance in getting an introduction to the Minister of Labor in order to advance workplace violence initiatives. Those are the types of relationships that make our work a little bit easier. So my question that I typically ask of various audiences, are you intimately familiar with your corporate strategic plan, your hospital corporate strategic plan? And I'd ask you another question. Does that corporate strategic plan specifically speak to culture, safety, violence, any one of those, safety in general? And are your board of directors and your senior leadership team asking you questions about your experience and the data related to violence? The other great thing about corporate strategic plans, it's always about what are your tactics, but then the next big part of it is what are your measurements, who are you benchmarking against, and how are you performing? And so all of those are very, very important things to be discussing, and it forces you to sort of mine your data and pay attention to benchmarking it, be it your competitors. I don't think we get competitive in public health, but who are you comparing yourselves to and how are you performing against those people? Just put this up, I added this to the slide deck for Rob Devitt and Erna, who presented this presentation at the OHA a few months ago. And at the time, this was a recent incident that happened, a workplace violence incident that happened in BC. And I simply put it up there. I'm not going to go through sort of workplace violence prevention statistics in healthcare, but safe to say that although I think as an industry, healthcare is by and large moving in great strides related to workplace violence prevention programming and awareness, despite our best efforts, bad things happen. And so Erna and I were talking on the drive up this morning about every morning I wake up and I wonder, what could happen related to workplace violence, because the reality is it exists, and best laid program is never ever going to cover every eventuality. But better to have be starting from something more than zero than sub-zero.
Well, and the other piece of this is that since 2010, workplace violence is the law. Like, to prevent is the law. So employers have had to put in place programs, measures, procedures, and to make sure that workers are protected. And unfortunately, across the province, there hasn't been a lot of assistance from the Ministry of Labor to actually help employers get to that stage. So we're really hoping that this presentation helps you get to where Toronto East is and to engage the senior team. And we can tell you how important it is to gather your statistics as Joint Health and Safety Committee members. Hopefully you're all getting your accident reports within 4 days of every accident happening. You get summaries at your Joint Health and Safety Committee. Those are all tools, as Nancy said, to learn to speak that language to the senior team, to be able to demonstrate to them the significance of the problem, as well as what the law says that you have to do. And ONA surveyed our members back in 2009, and we have over 60,000 members, and of those 60,000 members, 54% said they have experienced physical violence. Now, when you look at the WSIB data, okay, they say that they break it into schedules, but for the entire province in 2013, there was 2,087 lost time injuries alone in 2013. Now, when you think about how many ONA members alone we have, which is 60,000, 54% say they've been physically assaulted. Something's wrong with the data, right? Which a lot of our members and just healthcare workers in general, are accepting that it's part of the job and they're not reporting it as they should be. And if you're not reporting it, then how can management actually do something about it? So of those 2,087 lost time claims, 30.6 or 639 of them actually came from the healthcare industry. And ONA put together a pictogram for our biannual conference just to demonstrate when you compare healthcare to manufacturing, construction, and mining, which there's such a big focus on health and safety in those areas. When you look at workplace violence alone, not to mention the others, you can see that we have, compared to mining alone, we have more than 600 times the rate of workplace violence than just in the mining industry alone. And when you think about the police who are captured under government services, as are correction workers and EMS and fire, they have just under 700 lost time injury events. And so it's safe to say that healthcare workers are getting beat up more than the police and the correction workers. This is Lori DuPont, our member. I don't know if all of you heard or remember the incident at Hotel Dieu Hospital in Windsor. Lori DuPont was murdered by an anesthetist at Hotel Dieu Hospital on the job. And, you know, when we called for a coroner's inquest, and during the inquest, Dr. Jaffe testified. He was an expert witness, and he testified that there was 83 missed opportunities to have protected Lori, and it ranges from the anesthetist breaking another nurse's finger, to supervisors telling nurses to mind their own business when they told him that he's going to go postal. I mean, I could go on and on about these situations. But he did identify that there were all these opportunities that could have actually have kept her alive that weren't taken. And so it's really important to actually put in place the proper measures so that you can respond to workplace violence when it is escalating.
And so, in and around the time of the Lori DuPont inquest, our CEO, now retired, Rob Devitt, recently retired as of April 1st, tends to be a walk around the building guy and likes to play hockey with played hockey with the TGH hockey team, and there were lots of our security guards or protection agents, we now call them, who were on the team. And love to have a soda pop after the game to talk about the issues of the day, and there was an awful lot of chatter about the security guards recognizing a trend in an increase in workplace violence related to the obvious weapons and related to the not so obvious weapons, but weapons nevertheless that are readily available in healthcare. We'll talk about that a little bit later. But that the safe, if you will, in Emerge was overflowing with, you know, just a significant increase in having to store weapons that were confiscated either from patients, the public, or family members. And so Rob made it his business to sort of say, well, you know, I'm an open door kind of guy. Everybody tells me that's the kind of CEO I am, and I have all kinds of people coming to talk to me about other kinds of concerning issues. Why isn't that I haven't, you know, this is a surprise to me, why haven't I heard about this before? And went out into the clinical areas to start having some discussions with clinicians and physicians about their experiences related to workplace violence prevention. And sort of validated what he'd heard from the security guards post-hockey, that in fact this was a reality, and that regardless of open door policy, that it is just something historically, traditionally, that has not been sort of openly acknowledged or discussed at that time. This is going back to 2006, hopefully we're in a better place. But they're sort of a general understanding of why should I report it, nothing would get done. This is just part of the job. It's time and energy to fill out an incident report, and fundamentally just a cultural, not a propensity to sort of articulate, recognize, and respond to workplace violence issues. And I can tell you, I'm not from healthcare. I'm from public sector. You couldn't imagine anyone being further away from healthcare. And I was struck in my early days of, you know, going into Emerge and inpatient mental health in terms of, you know, incidents sort of happening in people, healthcare providers of all description sort of with their backs turned towards what I would perceive to be as a newbie, such a dire, potentially risky situation. So that part really resonates for me. So just a recognition that there is a lot of work to be done, and not a lot of perhaps faith or hope, perhaps born of past experience that anything was going to ever be done about it, so why get all up in arms? So we added this slide in originally just talking about, wouldn't it be great if we would treat workplace violence prevention or incidents with the same sense of urgency that we might have related to a staff adverse event, or more recently, because Ebola was, at the time we were drafting this presentation, was very, very much on the front pages if we would get as excited about our workplace violence prevention strategies as we do about high infectious disease prevention. And so, I think that we'll talk a little bit more about this a little bit later, but the key for us, and I guess another lesson or recommendation might be, is not to treat patient safety or staff safety any differently than patient safety. Where at all possible, you have to align your tools and resources, your culture, just culture initiatives, all in line with the same. Don't be trying to create two different programs. So I want to talk a little bit about our strategic partnerships, because we think that this has really helped us grow our program very comprehensively. Recognized really early on, and in large part due to ONA's representation and sitting in on the jury inquiry related to the Lori DuPont murder, that they had a lot of grassroots knowledge about what went right and what went wrong in that particular incident. And we wanted to tap into that expertise in terms of developing our program. So I guess our next recommendation is don't try to go it alone at this point in time. If you feel that your program needs to be enhanced in any way, take a look at what resources and or partners you might have and leverage that expertise. And so at that time, this is back in 2006, we knew that ONA was an expert in workplace violence prevention. And we also invited what is now PSATCH representatives to sit on our committee. We asked our local police liaison officers to participate. And together, we created a program. And what we did in the very early days of bringing people together was really talk about what's our shared vision going to be. And together we came up with zero tolerance. And we wanted to see more incident reporting. So what was the specific organizational behavior we wanted to see at frontline level and at supervisor, managerial, and leadership level is bring it on. We want more incident reporting.
I have to say, Rob Devitt, the CEO at Toronto East, actually, so he approached us in 2006, right, 2006, so long ago now, but we were at an OHA conference, and he was speaking with the Minister of Health. I was being introduced to the Minister of Health. He said, oh my God, I've been trying to reach you, right? And would you be interested in working with us to become leaders in violence prevention in the province? And that was definitely something that we weren't going to turn down as an organization, to have an employer who actually wanted to become a leader. And I said to Rob, we would love to, providing a couple things. One is that you sit on the committee and you chair it. And he said, done. So I'll attend if you do, was kind of the trade-off, and that the Joint Health and Safety Committee be involved, done. That if there is any type of discrepancy or, we don't agree on something, that that we will still call the Ministry of Labor in or file grievances, yes, no problem. And basically the committee was formed within, I'd say, a month. I mean, this man meant business, right? And so I think one of the key pieces here, and I don't know how many from senior leadership are sitting in the room, but approach your CEO, because if your CEO is not committed to this process, it's not going to work. And, you know, get the CEO's commitment, somehow figure out, bring the CEO to your joint health and safety committee meetings. That's all I can say. It's, you know, Nancy's going to talk a lot about the business case and making the business case as well, but it is also the right thing to do, and it is the law. So I think if nothing else, you know, bring the CEO in, and there's a lot of benefits to actually being out there, being known as leaders in violence prevention as well.
So this is, I think, the original committee back in 2006, and all I can say, I guess the recommendation is initial days of our workplace violence prevention committee work was really basic policies and procedures and putting to paper processes that we were already practicing. But now, over the years, our committee work has really evolved to monitoring statistics, mining data, identifying trends, and really trying to collaborate with our stakeholders and partners at a higher level within the healthcare system at large. So we've moved from policy and procedure up to advocacy, recognizing that our training and learning and policy evolution is always going to be work, but we think we've been successful in large part to creating, rather than having the Joint Health and Safety Committee be sort of the sole driver of workplace violence prevention, we created a small subcommittee that reported into the Joint Health and Safety Committee. And we invited people to participate in workplace violence prevention that had a passion and interest and some skill and expertise. It was cross-functional, made up of leaders, mid, the lower, senior levels. As Erna's already indicated, very, very critical that our CEO put some spit in the game and participated. But as well, we also engaged our police partners to do some of the domestic violence training. We used ONA, Erna and our local president and our labor relations officer to actually do the legal training of our supervisors and managers, because they had the interest, the expertise, and the knowledge. So I would say that all of that work in the early days, we took our smaller working group, our Workplace Violence Prevention Committee, and broke it down even further into smaller working groups. So if we needed to create a poster, who was going to be on the poster committee? If we were going to create a patient flagging program, who were the experts that we wanted at the table? So my recommendation, at least it worked for us, is not trying to sort of do this via big committee and create small working groups where people truly have an expertise and an interest and can feel like they're contributing to the work at hand.
I wanted to say, so just to give it some perspective, because I know a lot of you are on the joint, how many here are on Joint Health and Safety Committees? Good bunch of you, right? And the laws, the healthcare regulation requires healthcare employers to consult the Joint Health and Safety Committee in developing all measures and procedures. So this cannot happen, this process cannot happen without going through the Joint Health and Safety Committee. Saying that, however, it was really important that we had the larger committee with all the different experts and managers from Emerge, security was at the table, police were at the table, union reps were at the table, we had the co-chairs at the table from the Joint Health and Safety Committee, and then documents would get created. Nothing ever got approved without committee consultation and approval first. So it always went back to the committee to say, okay, here's a draft of something that we're presenting, that we're thinking about, what's your feedback? And then it would come back to the large committee and really make changes. But because the committee was already sitting on, representatives from the committee were sitting on this larger committee, it made it quite easy because there was a lot of faith in who the committee had sent to participate. So just to kind of give you an idea of how it worked. And the other thing around policy and procedure development, when you look at the legislation, it's very ambiguous, right? You're like, okay, what do you do? Well, I have to have a procedure of how to, measure and procedure and how to summon immediate assistance. Well, what does that look like, right? I have to have a procedure on reporting and something that sets out how to investigate. But that's not all. It also says to do risk assessments and to put in controls based on the risk assessment. And so there's a lot more measures and procedures that have to be developed than just what the legislation spells out, especially for healthcare, because you also have to look at the healthcare regulation, right? And so when you're thinking about it from that perspective, this is, I think, where ONA came in handy being at the table, is because we were really trying to work hard with Torontoese to prevent them from being, being investigated by the Ministry of Labour, so that we could actually say we would not challenge your program because it's sound, right? So if they had a procedure that they were already working on or that was being implemented, someone may not have just put it to writing and may not have consulted the Joint Health and Safety Committee. So then they would take it back, someone would draft what they actually do, they take it back to the committee, it would get tweaked, and then it would get approved. So just keep that in mind when you're working on this, and if your CEO says, yes, we want to do this, that these are some of the things that you'll want to try and get into writing, just to help the employer stay in compliance.
So the last thing I want to share, just in terms of the mandate and how the Workplace Violence Prevention Committee works is perhaps small but very, very important, is we made a commitment early on that we were not coming to the table as labor and management representatives, that this wasn't an extension of grievances, reports or grievances, that it was really going to be about culture. And that is why the shared vision, zero tolerance and an increase in incident reporting was so important to the work. So we really coach and counsel everybody who comes to the table to remember that we're coming here with fresh eyes and with a view to be collaborators and partners.
Rob Devitt, their CEO, actually also said to me, if I do not see an increase in incident reporting within 1 year of the program being implemented, then I will take it as a personal failure. Like, what CEO says that, right? Like, that was, to me, a man who was totally committed to this project, and we knew that it was going to take off and go places.
So I think we realized early on that we had the CEO's support and interest, but it's another thing to sort of get the next level of management and frontline staff engaged. And many of our leaders come from clinical backgrounds, so the old traditional beliefs of it's putting up with workplace violence and abuse is just sort of part of the culture. I grew up and survived it, therefore others shall too. Yet we had to sort of take a moment and step backwards and think about how do we truly get middle and senior management and frontline staff truly interested in their personal well-being related to violence within the workplace. And some of the strategies that we used were simply to give people aha moments, make it very personal, using videos of perhaps incidents that occurred within the workplace where it was safe to do so, making it graphic in terms of sharing the weapons that, of course, the security guards were talking about quite a bit. And these are some of the obvious weapons that were confiscated, but I have another photograph and another presentation that looks at all of the clinical tools that you guys use day in and day out, be it scissors, needles, etc. So we, all of which, as I'm sure many of you can attest to, can and have been used as weapons as well. But sort of just making it, talking and debriefing on specific incidents that occurred, even showing video clips of, a patient sort of whirling around an IV pole in the middle of the merge and everybody else's back is turned, away from this particular incident as if it was, something simply that goes on every day, which it does. But just as a demonstration of, there are risks and it's okay to acknowledge them. And we'll support you in terms of evolving through that process. That's a big if though. in terms of how do we support. That's, you know, what would make people think that we would support them? What would make people think that it's worth their time and energy? And that's where you get into, are you truly committed in following through on incident debriefs, learning from the opportunities, sharing those opportunities of learning, and then building in those learned lessons into the program. So
I think from our membership perspective across the province, just hearing from others across the province, one of the number one complaints our members have is that I told my supervisor about something about workplace violence and then nothing happened. So what's the purpose of saying or doing or telling them about it if nothing's going to happen? That's why it's so important to have the leadership commitment from the top down to help supervisors be able to respond when something happens, because they don't know what they don't know as well, right? And what we found at Toronto East was, you know, the culture wasn't there. People didn't believe that someone was actually going to do something. So when they actually saw it being put into action, people were, you know, starting to investigate and follow up and contact people. And, you know, it was this whole change of culture that started to happen to say, oh, I can actually report and feel confident in reporting, knowing that something will change.
And last but not least, at the time that we started looking at workplace violence prevention, we had some other concerning trends, and that was absenteeism above benchmark. Our staff engagement scores were not where we wanted them to be. Our turnover and retention statistics were also not where we wanted them to be. So it would have been easy at the time just to go it along with, we need to make this place safer and we need to minimize, eliminate violence. But what we decided to do is take a broader picture and say, clearly we have a cultural issue starting back in 2006, and it's demonstrating itself in many ways. How can we address all of those concerns from a business value perspective, while at the same time demonstrating our commitment to being a caring employer. This is our current, it was sort of our first blessed poster, and it remains our current poster related to communicating our zero tolerance policy. And it was actually our first sort of very visual demonstration of commitment. Our first, I need to recognize that I believe that, and it was probably Erna that shared this way back in 2006-07, St. Mary's Hospital in southwestern Ontario actually had one of the very first zero tolerance posters. We didn't reinvent the wheel, we took theirs and we worked with it, TEGH'd it. And actually, this version that we're currently showing you, and is our final version, our very first draft was pretty close to this. Very clear, very direct, and I guess almost ready to be blessed by the committee, and then a number of committee people and stakeholders that we vetted this first poster with sort of came back and said, well, it's pretty harsh language. We're going to be telling patients and families that we actually have house rules and that will actually have consequences for them. And a lot of uncomfortableness from frontline staff, leaders, physicians. And I suppose another lesson learned, if our CEO were here, would be that sometimes you just have to step in and do the right thing and have a little bit of courage. You wouldn't say that, but I'll say it on behalf of the leadership team at Toronto East General. Have courage to sort of say, no, you know, we need messaging that is direct, that is clear, that articulates what the consequences are. We have to do this for patients, visitors, and public, but more importantly, we have to do it for our staff and physicians and the stakeholders within these four walls. So, you know, so the second version was puppy dogs and kittens, all very soft language, looked beautiful, but when you read it, you weren't really quite sure what the message was going to be. So we reverted back to the first draft.
I have to say, across the province, there are more hospitals now, thanks to Toronto East General, that are going with the stronger language, but there's still many that are spending, I'm talking months, of developing a poster. And when you think about it's something that goes on a wall and messaging, you know what I'm saying? It's about let's get to it and let's get it on there. And the CEO, because we did do the presentation together, and he said it was enough. Like, let's go back. This whole purpose was to protect workers, and we have to do something about this. And I'm going to step in and make this happen. And we are going back to the stronger language, and he took a stance. So that's why I said very important to get your CEO's commitment for a workplace violence program, and in order to do something like this, because you're going to have those naysayers that are going to say, oh, it's too harsh, and oh, our patients and everything else. But we have not seen, well, you'll talk about the unintended consequences, but we have not seen any real flashbacks since the unintended consequences.
So certainly,
Questions? Or?
yes.
So I don't have a problem with the language. I think it's very direct and it's informative. My concern was that you mentioned, you know, that it was important to let the public, the families, and the patients know. What about response to staff? What if the person who is actually violent is a staff member, or who's doing the bullying is a staff member or a physician? How does that work in your organization?
So we have a workplace violence prevention policy and a code of conduct policy that links into our expectations of staff, anybody, any stakeholders who carry on business or contractors, staff, physicians, about what is expected of them. And they actually go through training as well. So an I-Learn module in terms of the specific responsibilities and expectations, and then an in-person workshop to talk more specifically about de-escalation strategies and expectations. So yes, this is a very public notice, but we also have a similar messaging in our code of conduct. So just speaking about, Erna alluded to unintended consequences, another lesson learned. So we rolled this out, we did some in-service education for staff. What does this mean? Of course, we incorporated it in our external communications with patients and the general public. But we did learn that we needed to do more education with staff, because we had some incidences after the posters were up throughout the hospital where staff at the very iggling of a patient or public or family member starting to escalate and ask that to act out would sort of immediately draw the person's attention, read this poster and settle down. And so we recognized that we only had done the most basic of education when we were rolling out the poster, and that it really required more comprehensive training on conflict resolution, de-escalation strategies, and we've also incorporated emotional intelligence training into all of this, which I can allude to. So recommendation is don't just roll out any kind of signage without sort of considering how a person might use signage, and give your staff and physicians, your stakeholders, all of the tools that they need in order to be able to use the program effectively.
I think Rob alluded to, or he said it actually at the OHA conference, which was it would have been very easy just to take the sign down, right? But it wasn't the sign, it was just the training. Staff needed the proper training, and they had to give them the proper training. So like Nancy said, it was about figuring out, okay, what are the messages that you need to pass on to staff? And you got to remember again, just from the owner perspective and what the legislation says, it says when you develop a measure and a procedure, you also have to consult the Joint Health and Safety Committee. You have to provide training on those measures and procedures. So it's about consciously thinking about everything that you're developing, and then thinking, okay, at some point we have to develop the training plan. We need to talk to the committee about what will that look like. I can tell you one of our workplaces, please don't do this, was trying to do training on devices, summoning assistant devices, and they figured the best way to actually get people to read the policy was to post it on the bathroom stall, because while they were sitting, what else are they going to do? So that was the training that they provided. Well, I can challenge that with the Ministry of Labor at any point pointed out, I'm sure they didn't have training records of anyone who had actually read it, which wasn't actually training, it was communication. But, don't do that.
Nancy, when you were talking about it, and you're probably going to talk about it when you're talking about business case, but to put that plan into place, and obviously required your CEO's engagement, but it requires a lot of money to train everyone and to keep the training current. And you talked about 3 specific different types of training that you did, so that probably did require a fair financial commitment from your organization to ensure that everyone was trained, right?
Yes, it does, and I will talk about it, but the short story is and this is a methodology we tend to use for most education, organization-wide training, we use a train-the-trainer methodology. So for the first number of workshops, we had the experts do it, but then we had frontline staff participate as train-the-trainers. The reality is you have to be smart about how you're spending your money, most definitely.
And the first round of training that they did, because I remember Rob coming in there and saying, okay, we need the biggest bang for our buck. We have to do something about workplace violence. We need to do it quick. And so, like Nancy said, remember, we broke the committee into smaller committees. So here, you work on signage. We didn't just do one thing at one time. And that'll take years to get, a program developed. So if someone worked on the signage, then we said, okay, we really need a means to identify patients who have a history of violent behavior. And someone worked on the flagging procedure. And then he said, I really need to protect the highest risk areas right now. What do we do? And that's when they hired the outside consultants and did the trainer training. And it was about recognizing the signs and symptoms of workplace violence, de-escalating, and then some hands-on techniques to break free as well. So, Emerge and mental health, I think, were the first group that actually went through that training.
Yes. So before we get to the training piece, I'll just talk briefly about our risk assessment process. And again, we didn't reinvent the wheel. We used a workplace violence risk assessment tool, and now owned by PSATCH. We've taken it, we've tried to online it as much as possible. We're working on getting it put on tablet. But in the interim, we've over the years streamlined it so that we're making very, very good use of people's time. So we didn't set about to try and create our own workplace violence prevention tool. Quite frankly, we did a bit of a mini search in terms of what was available in Ontario. But we have to say that we very quickly sort of put our hands up and said, let's try this, see if it works for us, and we can TEGH it as we go along. What is, I think, unique to our program is prior to actually going on a unit to do a physical workplace violence risk assessment, we actually send out a pre-risk assessment survey 3 weeks in advance of the physical assessment. And that is really just to get a baseline of what the staff know about workplace violence prevention, what the experience has been in terms of reporting, what, if they did report, what did they report, the types of violence or abuse, and what recommendations they might have. So it gives us, as a committee that goes on to the unit to do the risk assessment, a bit of an understanding of where the information, knowledge gaps are, and we're not spinning our wheels. So we go onto the unit with very targeted questions and information, which, to my knowledge, I'm not sure that any other organization is currently doing, but we find it of value, and it will certainly give us a good idea of when we resurvey and we reassess where our programs are working or where we may need to amend them.
I highly recommend it as well, because you want to create some sort of a baseline to be able to measure yourselves against, and to be able to say, where were you at in 2015, and where are you at in 2017 and 2018. And I look at where we were back then, and now we're out doing presentations across the province, and we did the Miami conference, and we're out there telling people now about the program. So, and you can be there as well at some point.
So to your question, again, we hired an external vendor who was experienced conducting violence risk assessments in healthcare at large, and to do our emerge department, our inpatient mental health department, and the perimeter of our facilities, and looking at our exits and entrances and our cameras. But the agreement is you will have the Workplace Violence Committee members who will be tagging along on all 4 of these initial assessments, and your job is not only to conduct the assessment, but also to train the committee members so that when you finish those 4 initial ones, we're able to move forward together, you know, with some ad hoc support when needed, but generally that we become self-sufficient. And, you know, that has worked well. We have a pretty solid group of assessors. And we've only recently brought back the same external vendor to redo our emerge, redo our inpatient mental health, and our perimeter again. Because it's been 4 or 5 years, we want fresh eyes. We want to see what we, you know, still outstanding, what's new within the industry. You know, what other hospitals have identified as risks. So the whole process, once a physical risk assessment is done, the manager, supervisor, frontline staff, joint health and safety rep off the floor, all come to the Workplace Violence Prevention Committee and present the action plan. So it's, you know, what are the short, intermediate, and long-term plans? Again, this is not pie in the sky. It's not like there's 25 things that need to be done and it costs $15 million effective immediately. It is what are the short-term fixes, what are the intermediate and the dollars, and what are the longer term. So one of the recommendations coming out of the workplace risk assessment on inpatient mental health was that the nursing station needed to be moved from the center of the floor to closer to the entrance exit. And so that didn't happen the next year. It didn't happen, you know, it happened a couple of years later. But through, you know, through the commitment of the Workplace Violence Prevention Committee and the leadership team and the staff on the unit with the physicians, we now have a much better setup for the nursing station.
And I can say, because I have my hands in many different employers' programs across the province, the ones that started off and they're doing their assessments themselves, they're not very good. Because I've seen good and I've seen really bad. And again, people who are doing the assessment who haven't been trained to do these assessments, how would they know what to do? Like, I mean, so you can't really fault the people who are doing it if they don't have that expertise. And so we highly, highly recommend, you can hire who you want, but looking for, I think, Toronto East Youth Stay Safe. Another group that does them, we've heard, is Safe Management Group. I haven't seen one of their reports, so it might be something that you can look into. You know that some of the hospitals that have just recently had some very significant violent incidents are now using the group that Toronto East had. I've seen the reports from these organizations, and they're very comprehensive and they're very clear. And the, you know, South Lake Hospital has used them. We're working collaboratively with South Lake Hospitals as well, sharing our knowledge of the program and helping them through their program as well. And so they've used them. I mean, you may get 100 or more recommendations, but don't be alarmed. They're not all like expensive to fix recommendations. Some of them are so simple. Some of them is just putting something in writing and teaching people a new way of doing something, right? And but it's just looking at it from another perspective and another lens that you wouldn't even have thought about looking at it, right? So very important.
I'm going to do a time check here and see it's 10 to 2. Security measures. Clint Hodges, who was our manager of protection services, normally does this slide, and we would have had him join us today, but he's at another conference presenting, so divide and conquer. But a really big outcome from the external vendor coming in and doing the perimeter risk assessment was, in early days, just looking at the number of cameras on property. And in fact, this is needs to be updated. We're now up to 400 cameras on our